Good evening, everyone. Welcome to our webinar tonight on post-transplant recovery. I'm Karen. I'm with Mended Hearts. Let's give it just a little bit of time here. We still have some people coming in from the waiting area, so just a few more moments. I think we'll get started. So again, I'm Karen with Mended Hearts. Welcome to everyone. Thank you for joining us tonight for this very informative session on post-transplant. Just a couple of housekeeping items. Everyone, all the attendees are in listen-only mode. And just keep in mind, we will not be able to answer any specific medical questions that you have related to your specific condition. So maybe just kind of take some notes and take that to your own physician. Please be sure to type your questions into the Q&A box so we can answer them at the end of the presentation. This webinar is being recorded and will be available on the Mended Hearts Inc. website, which is www.mendedhearts.org, and our YouTube channel. And today's webinar is part of our Empower Transplant series, and it is sponsored by Natera tonight. We have lots of resources available through Mended Hearts and the Empower Transplant series. As you see here, those are some samples of some discussion guides. So be sure to check out the resources we have, the free resources we have available to you at mendedhearts.org/empowertransplant. And I'll pass it over to Glenn Kelly. He'll introduce our speaker. And again, thank you for joining us this evening, and be sure to put your questions in the Q&A.
Thanks, Karen. Hi, everybody. As many of you know, I'm a transplant recipient, heart and kidney. And I'm excited tonight for our speaker, Dr. Shelley Hall from Baylor University in Dallas, Texas. She's certainly a nationally renowned leader across heart failure and transplant, as well as MCS devices. She's held many leadership positions across the transplant as well as advanced heart failure world, and I know she currently serves as the vice president of the OPTN. So without further ado, I want to turn it over to Dr. Hall, who can not only inform us, but I think entertain us along the way. So we're going to do a quick slide swap and move it over to her.
Oh, yeah, I see replace current share on my side. All right, let's get these going. We'll get slide. All right, seeing it correctly?
Yes, we are.
All right, so having Glenn say I can entertain is a challenge because Glenn's one of the most entertaining patients I've ever had. I hope that this is informative and that it covers most areas for you, but also stimulates questions to your own physicians or questions you want to ask if you're considering transplant. So I really divided up the post-transplant journey in timing because that's how we think about it from the physician side, because that is kind of what happens with the disease. So we'll talk about hospital stay, then the first year after discharge, then years 1 through 5, and their years 5 onward. And so the hospital stay is really divided into 3 phases: the immediate post-operative, the ICU, and the floor. And so we're going to start with the early post-operative phase. And, this picture of somebody with all those IV pumps and monitors, that's pretty realistic of what that early post-op period looks like. So when you get a heart transplant and come out of the operating room, you're on multiple IV drips. Some of these medicines are called inotropes, like dobutamine, epinephrine, milrinone. These medications are stimulating the heart to pump because every heart has just gone through a traumatic journey in an ice bucket of some type. And they all kind of wake up from that journey differently. And so they need varying levels of support. Then there's also IV medications sometimes to keep your blood pressure up, what we call pressors. There are other medications, sometimes with antibiotics on the IV. So usually at least 4 to 6 IV pumps is the minimum. Almost everybody nowadays comes out of the operating room on the ventilator. In the old days, sometimes you could be extubated in the operating room, but that's very rare nowadays. You got some immunosuppressive medicines by IV in the operating room. You may have gotten some special types called induction or if not needed, then you would have just gotten standard, which is typically steroids and a type of medicine we'll talk about called MMF. And then there may be special considerations if you've got a lot of antibodies or are highly sensitized where you got something special. Then, of course, you're going to have wounds and catheters, and you need a giant team to take care of all these things. So let's talk a little bit. As I mentioned, the IV drips, the ventilator, immunosuppression, how you start your immunosuppressive journey. I know this is kind of a scary picture, but immunosuppression is both your friend and foe. And our goal when we are using these medications is to use enough needed to prevent an acute rejection episode, but not so much that you have no immune system left and then you're subject to infections. As I mentioned, you're going to have a lot of wounds. You will have chest tubes coming out of your chest and abdomen. You will be on a breathing tube for the ventilator. You will have a catheter in the bladder. You will have multiple big IVs in your neck and an arterial line in your arm. And that's just the standard stuff. And then, as I said, it takes a multidisciplinary team, and we'll talk a little bit about this, to take care of you in the ICU. When you move to the ICU, this really is teamwork makes the dream. The most common things in the first few hours that we are looking at is, are you bleeding? This is a big surgery, and if you've had prior surgeries, you can have a lot of scar tissue, and that means that you will be more likely to have bleeding. If you've had an LVAD and that's being removed, or you've had prior bypass surgery or congenital heart surgeries, there's a high risk of bleeding. And so sometimes there's so much bleeding that your tissues swell up and they can't close the sternum on the initial time. And so it could be open. And then they'll remove the ICD if they can. If it's unstable and you've been in the operating room a long time, they may not remove the ICD because they just want to get you out of the operating room. So that's really the crucial first few hours. Are you bleeding or not? Because we can rarely correct bleeding with medicines that they do in the operating room before you leave. So if you're continuing to bleed in those early hours in the ICU, you usually have to go back to the operating to look for why you're bleeding. The next big thing we're looking at is, how did this heart wake up from that icy journey? Some wake up very well, but some have what's called primary graft dysfunction, which means it's not working normally. And there are some risk factors: older donors, long ischemic times, meaning the time from getting the heart out of the donor and functioning in you. There can be natural emboli that occur through the process of sewing everything together. And we do know that this is becoming more common. And that is because our recipients are sicker and sicker because, again, there aren't enough hearts for everybody. So people waiting on the list get sicker. The sicker you are going in, that's a sicker environment for the new heart. And then our donors are getting older. Our society in general is getting less healthy. So that includes our donors. So our donors are more likely to be older now, to have diabetes, hypertension. And so they're not as healthy as they were 20 years ago. Now, primary graft dysfunction is usually temporary, but it takes a lot of TLC. The ultimate treatment is that we support you and that heart until it tends to settle into its new home, essentially. Now, sometimes that means high doses of medicines. Sometimes that means machines to circulate blood for the heart while it is recovering. Most primary graft dysfunction will improve or normalize in the first 24 hours. Some take a little bit longer. It is the fact the team is prepared for it, is recognizing the early signs of it, and then intervenes with medical or mechanical things in a timely manner that make the difference. The next thing that happens in an ICU with all those lines and tubes is your immune system has just been suppressed. You've got tubes and lines everywhere. You can get infections. And hospital infections are going to be nastier typically than community infections, because bugs that live in the hospital live in environments where there's been antibiotics, so they can be resistant. The real key is getting all of these tubes, lines, etc. out as soon as possible. As soon as you're doing well enough to get off that breathing tube, get off the ventilator. As soon as we can decrease the number of lines because you're not on so many drips, get those out. As soon as you can sit up and pee on your own, get that catheter out of the bladder. All of these things, the sooner we can get them out. While they may be convenient for some reason, they are an infection risk as long as they're in. The next is, we're not trying to be mean. We are trying to get you up and moving earlier, because that's the best way to protect you from pneumonia, is moving. The longer you're bedbound, the more likely you're going to get pneumonia. And then you should be at a transplant center that has transplant infectious disease experts. The regular ID consultants don't understand all of the nuances that occur with transplant. And most transplant programs are going to have a transplant infectious disease expert to help. The other thing is, you just got a whole bunch of steroids. The majority of patients going to transplant already have diabetes or borderline diabetes. Then you get a bunch of steroids, your blood sugars go crazy. So most patients will be on an insulin drip coming out of the ICU. And then as the steroids go down and one of your medicines for your heart, epinephrine, goes down, your blood sugars will come down, and then they'll eventually convert you to the regular sliding scale insulin. The next is, because people are waiting longer and more of them are waiting in the ICU, they're getting more deconditioned. So they're going into the ICU weaker. And as a result, you're weak going into a big surgery, and then you come out, you're certainly not stronger, you're weaker. So trying to get you out of bed as quickly as possible, get physical therapy going on day one, is the best way to help your body recover. So we're not trying to be mean. We're trying to prevent you from getting more complications. If all goes well in the ICU, most of those IV drips are weaned down to 1 in the first 24 to 72 hours. You're usually, if all is well, off the ventilator within 24 hours, and they usually will, depending upon what time of day you're taken off the ventilator, up in a chair shortly thereafter. And then if you pass the swallow evaluation, if you've only been on the ventilator a day or so, that should be no problem. If it was a protracted time and you're on the ventilator for many days, then your swallow muscles will be weak and you may not be able to eat right away. Once you're in that situation, down to a single IV, you're ready to go to the telemetry floor. Now, what happens on the floor? Going to the floor is great. It means you've got more freedom. You're on your pathway to getting out of the hospital, but it also means more work for you, because now this is where things are really kicking in for you. We are trying to rehab you more. You're doing more things for yourself. We're getting out any of those extra lines that are still in. We're trying to wean off the last of that IV. We're pushing you to blow on your IS machine and get up and out of bed to protect you from pneumonia. We're adjusting your medications, and you're usually given what we call a transplant binder or Bible that starts to tell you about your new world. This isn't a cure. This is a treatment. You're trading one chronic condition for another chronic condition. And so there's new medicines, new potential issues, and at least our transplant binders go into all that. And we have tests and classes and training, et cetera. As I said, lots to learn, a bunch of new medicines that you've never seen before. And not only do you need to know what the possible side effects are, but these medicines interact with other medicines. And so learning about that, we teach you about, don't take a new medicine from anybody without checking with us, getting that recovery. And then the psychological impact of all this, I mean, it's surreal. I mean, I obviously deal with it every day, but I truly still appreciate the miracle that's just occurred, and all that you have to think about with what it meant to get there, what it meant to get that organ. So you're on a lot of medicines. These are the standard medicines. We'll go into these in more detail, but on the left are the immunosuppressive medicines that most programs around the country use now, Prograf or tacrolimus. That's essentially replaced cyclosporin as the primary medication. And Cellcept or Myfortic is the second family, and then prednisone is the third. And then on the right are the other medicines that are part of the transplant regimen. So nystatin, which is an antifungal mouthwash, Bactrim to prevent some certain types of infections, a baby aspirin a day. Most transplant patients will get hypertension, and so many will go home with a blood pressure medicine. Everybody should go home on a statin. The aspirin and statin are to protect your heart in a way I'll go into in a minute, multivitamins and calcium. And then, of course, all the other medicines that you take for all of your non-heart conditions. So your list doesn't get shorter, it probably gets longer than the list you entered the hospital with. All right, now we're going to move to the discharge through the 12-month. And I call this raising a child. And it doesn't mean that you're all children, but I think about it this way. And I really talk to my patients about this, is that first visit when you are, coming from home and you're now out of the ICU, that's like going to your first day of kindergarten. We're your nervous parents. We're petrified something's going to happen. We're watching you like a hawk, and you're only away from us for a little period of time. And over the 12 months, you're going to graduate from high school. All right. And so that's sort of how I approach the first year. And it really addresses these major issues that we're going to review. So the first is the rehab, the general recovery. As I said, we start rehab day 0 in the ICU. As soon as you're off that ventilator, we try and get you up and in a chair and get moving about, especially because nowadays more and more patients are more debilitated because of being in the ICU, or they're being sicker by the time they get the heart transplant, that it takes longer to recover from the big surgery. The reality, though, is that most transplant recipients will achieve full functional ability if they didn't have any complications during the surgery, above and beyond what they had before, if you were only debilitated by heart failure. The next is the psychological aspects. As I mentioned, this is a incredible event that happens to you, and psychological adjustment is very important. And we know that when people have difficulty with this, with prolonged depression or anxiety, they have worse outcomes. They aren't as attentive to taking their medicines. They end up with more rejections and more infections, and therefore increased risk of complications and shorter lifespan. What we do know is that about 20% of heart transplant candidates have had depression prior to this because of being their chronic illnesses or already had a depressive disorder. This is going to it can be exacerbated because of this event. And then there's also post-traumatic stress disorder, very prominent in the first year, about, again, close to 20% within those early years, just because of the impact of going through a transplant. And so having a psychology support that's educated in transplant and understands is very important. Most transplant centers will have some type of psychological or psychiatric support. We have transplant social workers as well as transplant psychologists. Next is the medicines. As I said, lots of medicines, and learning about these medicines, getting used to them, determining how your body reacts to them. This is sort of a reality, this capsule that contains all your medicines plus a treatment for all of the side effects. When we're trying to do all your medicines, it's really like Goldilocks. It can't be too hot, it can't be too cold. We're trying to find the balance to have enough immunosuppressive medicine on board so that you don't reject, but as little as possible so that you don't get infections or increase your risk of toxicity or malignancies. So the evolution and change in these medicines is very slow. Most research for immunosuppressive medicines occurs in the kidney world because they do many more kidney transplants than heart transplants. And if the kidney fails, they can go back on dialysis. We don't have those kind of options in the heart space. So most of our medicines were researched and studied in the kidney world first, and not all of them went through repeat trials in the heart world. And that's just the reality. As a result, the heart world is very slow to try and change because of the challenges with trials and not certain if it'll be the same for a heart as it is for a kidney. The reality is most patients go home on a 3-drug regimen, 3 categories of medicine that I'll mention, and they're tried there and then weaned down to 2 by the end of the first year. The first category is the steroids. Everybody knows about steroids, those scary steroids that those athletes take. We don't really there's not a particular pathway that steroids act on. They're basically very nonspecific and very anti-inflammatory. And you're going to get a lot. You get a high dose IV in the IC, in the OR in the first 24 hours in the ICU, and then you'll get a large pill dose, and then it weans down over time. Probably 85 to 90% of heart transplant programs will attempt to wean you off steroids in your first 6 to 12 months. There's still a couple programs out there that keep you on steroids. And sometimes there's a condition you may have that necessitates staying on the steroids, but most are able to get off. Now, the side effects of steroids: high blood sugars, hypertension, hyperlipidemia, that can cause adrenal insufficiency because you don't have to make steroids because you're on steroids. It can cause muscle weakness. It can bother your stomach. It can cause osteoporosis. And it can cause psychosis. And I have had the occasional patient that had a psychotic break. I had one patient who on the floor just jumped out of bed, stripped off her gown, ran around naked with and didn't remember it the next day. And luckily it's rare, these kind of events, but we're always looking for all of this stuff. We know that all of these things are possible, and we look for signs that any of them are happening in you so that we can help get through. Usually they're transient and get better with decreasing the dose. The next family is calcineurin inhibitors. This is really the discovery that allowed the longevity of transplant medicine and people to survive. And that was cyclosporin was the first one. Tacrolimus, as I said, is now the standard for probably 80% plus of programs out there in the country. They each have certain side effects. So where cyclosporin made you hairy in all the wrong places, tacrolimus does have a risk of hair loss. Cyclosporin could make your gums get really big. Tacrolimus can sometimes cause tingling or neuropathy feeling. It definitely raises your blood sugar, and it can sometimes bother your stomach. They both can cause kidney dysfunction, high blood pressure, high potassium and magnesium loss. Again, we're looking for all of these and can address most of these pretty easily. The final category is called antimetabolites. The first medicine for that was azathioprine or Imuran. Now that has been almost universally replaced with the mycophenolate mofetil, trade name Celcept or Myfortic, because of the side effects. The Imuran can be much more toxic, causing bone marrow suppression, so you get anemic or low platelets. It can disrupt your stomach. It interacts with gout medicines, increased risk of malignancy and hair loss. The MMF family, as we call it, is not devoid of side effect potential too. It can cause peripheral swelling, diarrhea, GI bothering is the most common. We always start with Celcept, and then if you do have the GI symptoms, we'll switch to Myfortic, which has less of it. So we're monitoring again for all of these side effects. Some people have none. The fourth medication that most people don't go home on, but this can be used for certain situations, are called mTOR inhibitors. And the two common ones are sirolimus, known as Rapamune, or everolimus, known as Zortress. And these are for vasculopathy, which I'll go over, or they're kinder to the kidneys than the calcineurin. So if your kidneys aren't liking that tacrolimus, we'll sometimes switch you to this mTOR family. Again, it has a list of potential side effects listed here. The most common ones are mouth sores, protein loss, rashes, GI symptoms as well, or joint pain. This is what everybody's afraid of: rejection, okay? And I would say that we should be less afraid of it in today's world than we used to be. There are three types of rejection: cellular, antibody, and chronic vascular. And typically that's why they've been doing biopsies. It's been considered the gold standard, and some programs may do up to 20 biopsies in the first year. My personal perspective is this is an antiquated gold standard, and many programs are finding ways to reduce biopsies. Now, to go into the cellular rejection, usually when this is detected by a biopsy, it's a surveillance biopsy and you have no symptoms. And we really think that this may be overcalls now with our newer technology that I'll go into. It's now less than 1 episode per patient per year. Very rare to die from cellular rejection unless you just stopped your medications, and that's going to be a really bad cellular rejection. And the prevalence has gone down from almost 50% 15 years ago down to 10%. So it's just not as common as it used to be. Now it's usually treated with just some outpatient increase in steroids for a short period of time, and then an adjustment to the medications. Often you can have one of these in your first year and never have a problem again. This is what these look like under the microscope. The left, what we say is blue is bad. So the more blue on the screen, as you can see, going from left to right, that's more of those white cells coming in and attacking your heart. The problem is there are lots of other things that can mimic this. And also not all places have cardiac transplant pathologists. So studies have shown there's only about a 70% agreement when you send these slides out to central labs. So a lot of times they're overcalled because they don't want to miss a rejection. And we have found that patients have gotten unnecessary treatments for rejection. And so our program has moved away from biopsy as the sole surveillance mechanism. Antibody-mediated rejection takes longer to develop, but it can be more serious. This is when your body makes an antibody specific to this heart, and this is more likely to cause the heart to not work properly and may cause symptoms of heart failure. Certainly will eventually if not recognized. Now, this is usually occurring in the first months, but it can occur at any time in transplant if there are interruptions to your immunosuppression or something that really stimulates your immune system to rev up. There are special stains that are done on the pathology slides, and these are just 2 examples that look for certain types of antibodies that are common with this and show up with these special stains. So I've always been a challenge of the status quo. Even when I was a trainee and I left my training institution, I left going, can we do things better? And the reality is there are newer technologies for monitoring you because the vast majority of patients, 80% plus, are going to be absolutely fine without rejection problems. And so newer technologies have been developed, and the most recent is circulating cell-free DNA. So when our cells die in our body, they break apart and the DNA breaks into a bunch of fragments. This is normal. We're always turning over slides in our body. Well, you can now have a different source of DNA in your body. And so that's represented by the little green fragments, and the red is the donor. And so you can see there's lots of these fragments in the bloodstream. They don't last long. They disappear quickly, and we don't really know how the body gets rid of them. When we use this blood test, we can now screen for that percentage. And if your percentage is nice and low, we know that your heart's doing fine. It has very low levels of the heart cells being breaking apart. And then if that rises, that can be the first sign that there might be a rejection. There are other things that can do that, but that is now, it's just a blood test. And so in our program, this is how we monitor our patients instead of going and doing invasive biopsies. If you're going to do a biopsy, there is some new technology called the molecular microscope. It's continuing to evolve. And my philosophy is if I am going to go and put you through a biopsy and get pieces, then I want to do everything possible to look at that to know. And so this looks at the RNA inside those cells, and they've developed various patterns that help refine if it's antibody-mediated rejection, cellular-mediated rejection, or sometimes injury, just the injury of the transfer process. So these two are not used everywhere. So depending upon where you are or where you're looking at, these are things to ask about. How many biopsies are they doing? Are they using cell-free DNA, et cetera, so you can make informed decisions about how you want your monitoring to go. First year infections, most common are in the lungs. You know, you're out there, your immune system's depressed, you're around, everybody's sick, flu season, COVID, you name it. You're always breathing stuff in. If you get a neurological infection, that's probably your most dangerous infection to get in the first year. Luckily, that's very rare. The most common type of infection is viral. Again, we all get viruses all the time. Transplant patients are more susceptible, get them, and they may cause more symptoms. The most dangerous is going to be a fungal infection. Those are the hardest to get rid of. Remember, in these early months, you may not manifest a fever because steroids suppress fever. And so you have to be suspicious by other symptoms, or if you were exposed to something, to let the transplant team know. Because I've had patients with inflamed gallbladders who had no fever at all, and didn't really even have much belly pain because it was so fresh and they were on so much steroids. Now, the type of viruses are usually going to be in the herpes family. So that's your cold sore viruses or your genital herpes viruses. That's your zoster virus, the chickenpox virus. So, you know, these are why we're recommending vaccines, to protect you, because they're much harder to treat after transplant. They cause much more misery. The most common virus that's out there is the CMV virus. In the regular everyday patient, that's what causes colds. And 85% have that living in our body. Like the cold sore virus, once you've been exposed to it, it's living in your body for life. So 85% of transplant patients already have it in their body, and now we're suppressing your immune system. And then, of course, 85% of donors have it. So if you were one of the 15% and you get a donor that had it, you're going to be exposed to it. It's everywhere. So you can have sort of a viral syndrome. You can have fever, weakness, just feel cruddy like the flu, or it can be very specific to one of your organs, the most common being the GI tract with nausea, vomiting, diarrhea. The viral syndrome is usually the most common, and we monitor for this with blood tests. So we can detect a rise in the CMV virus long before it can cause symptoms. And so most programs will make this part of your standard surveillance in their blood tests. If you get revved up with CMV, anything that revs up, infections rev up your immune system. And so we know that means that if your immune system gets revved up, it's looking for anything. And so that does increase the risk for rejection. Every year, you're going to have a series of tests. And that's going to include various iterations of this. Almost everyone's going to get an echo. Not everybody gets an EKG anymore. You'll usually get some kind of chest and abdominal imaging, either ultrasounds or CAT scans. You'll get a whole bunch of blood work, the standard stuff looking at your kidney and liver function, your blood counts, your cholesterol, your thyroid, the viral panels. And then we're gonna harp on you tremendously to keep up with your health maintenance. So pap smears, mammograms, skin checks, colonoscopy, bone density. We'll go into this a little bit later. The reality is that we want you to keep those things up because you're immunosuppressed, which means that you're at greater risk for cancers, not so much new, but they'll grow faster. And so if we can check on them and find them early, we can treat them. That 1 year mark is when you'll get this cath, or what I call a heart catheterization. And for some people, you'll get an ultrasound within the blood vessels themselves, a biopsy. And then programs do it differently as far as frequency. Some do it yearly. We do it years 1, 3, 5, and 10. But that 1 year annual test where you get all this stuff, this is where I say you're graduating from kindergarten. You've gone from visits every week to twice to every other week to once a month. And then you have your 12-month, 1 year checkup. And we're looking at everything. And now I'm letting you go to college. And that's what I call years 1 through 5 is your college years. How are you going to manage your college years? Are you going to still be attentive to all this, or are you going to go a little crazy and think that you're invincible? And our job is to say, we want you to live your life, just don't go crazy. Usually, this is going to be one of two categories. You're going to have, we'll let you know if you're at increased risk of any heart issues. And usually if your heart did fine in the first year and that annual cath looks good, your heart's going to be fine through these college years. Now it's all those other medical conditions that we didn't fix, we didn't get rid of. You still have those. They're still going to do their thing, and monitoring and managing those. And of course, surveying and monitoring for malignancies. So I mentioned there were 3 types of rejection. This is the third one, called coronary vasculopathy. This is a slow chronic type of rejection. So the upper panel shows the barrel of a heart artery and an ultrasound catheters in it. And you can see that there's sort of a rim. I don't know if this arrow shows up, but this rim of stuff here. And that's the wall thickening. This is where it's gotten so thick, it's now blocking off the blood flow. Your own blood is continually passing through that heart. So it is continually touching and communicating with something foreign to it. And so it can have an immunologic reaction and call this thickening. The incidence of this is about 10% is found on the first year and 40% by 5 years. If you're going to have a cardiac death, this is probably why. Okay, and so our job is to look for this. Not all programs do this ultrasound. Some do just angiogram. In my perspective, angiograms detect it too late. They don't detect it until it looks like this. But by doing this ultrasound, we find it very early. And when you find it early like this, then you can intervene. The reason it's important to intervene early is because you don't have any nerves to your heart now. So if you had heart pain or angina beforehand and you had coronary artery disease, you're not going to have that angina now because you don't have nerves attached to your heart. So you're not necessarily going to have symptoms that this is happening. And therefore, I want to catch it when it's here so I can do something about it. We know that whatever thickening we find, it doesn't reverse. So the prevention of the thickening is key. So that's why we do the aspirin and statin as part of because that helps. And then those mTORs I mentioned, that is a medicine called anti-proliferatives. Those medicines slow down that thickening. So in our program, if we find that you have a significant amount of that thickening on ultrasound, we get this on board so that you never develop the really narrow. Now, I shouldn't say never, but we decrease the likelihood it will progress that far. As I mentioned, statins are very important and they should be started right after transplant. They don't help if you find this a year from now. The next thing that can occur, as I said, medical problems. So the medicines that we use to protect you from rejection, some of them your kidneys don't like. So that Prograft, that tacrolimus, they can worsen kidney function over time. About 7% will have kidney dysfunction in the first year and about 16% by 5 years. And as your kidneys worsen, this does increase your risk of death and complications. We monitor for this and we will try and adjust your medications downward as able, depending upon how your immune system is doing, or switch to those mTORs, those anti-proliferatives, to try and slow this process down. Also, many of you already have kidney dysfunction beforehand, plus high blood pressure, hyperlipidemia, diabetes over the decades also contributes to this. As I mentioned, high blood pressure. 72% of transplant patients will have high blood pressure in the first year. It's a big adjustment for most of you who've had low blood pressure. 92% by year 5. The guidelines for transplant patients is just like everybody else. Target blood pressures under 130/80. And almost all medicines can be used, and we communicate and work with your primary care doctor for the most recommended ones. Gout is very common and typically treated with non-steroidals and colchicine. Those can be kind of rough on the kidneys, which are already dealing with a lot. So often we recommend a steroid dose pack and then getting on a chronic medication to try and prevent gout. Hyperlipidemia, this is caused by steroids, your calcineurin inhibitors, your mTOR, all of these medicines do it, plus many you already have it. Same goals, target LDL less than 100. You should be on statins if you can tolerate them. They're important not just for the lipids, but for the heart graft. Diabetes, 21% of transplant patients have diabetes going into the transplant and will develop them, and the management is the same. We have started to see more and more of the SGLT2s utilized post-transplant, and so far seem to be well tolerated. The next thing is other things are going to come up. You're going to get an infection, or you're going to get a new condition and be put on new medications. The reality is that it's very important that you check for drug-drug interactions. There are drugs that increase the levels of your medicine. They can decrease the medicines. They can interact and suppress your bone marrow, and they can be harmful to the kidneys. So when we look at what can increase the levels, why is that a big deal? Well, that can put you into kidney failure if we don't know about it. So if you're put on some antifungal medicine for a toe fungus, need to know about it. If you're put on antibiotics, need to know about it. Certain blood pressure medicines like diltiazem can shoot that level up. Many HIV medicines, grapefruit juice, you'll be told not to drink grapefruit juice post-transplant. So if that was your favorite juice, need to get another one. Paxlovid, oh my goodness, Paxlovid, you cannot take Paxlovid for COVID. It can put you into kidney failure faster than anything, as it shoots your prograph level up into toxicity. Other medicines can decrease the levels. Why is that a big deal? Well, if they go too low, you could have a rejection. So many seizure medicines will do this. Rifampin, some HIV medicines, St. John's worts, even over-the-counter or holistic medicines can cause problems. So you should never take a new medicine without calling your transplant coordinator. Medicines that can suppress the bone marrow and put you into dangerous anemia, Bactrim, which we put you on and we watch for it, many antivirals, many psychiatric medicines, some seizure medicines. If you're on Imuran, that old medicine that I said, you can't take allopurinol for gout. So that's why another reason why we've kind of abandoned Imuran. So the bottom line is, when in doubt, if you get a new medicine prescribed, don't go and fill that prescription until you call your coordinator and find out. We had many patients that took the Paxlovid that their primary care doctor did. They were good intention, wanting to protect them and get them better from COVID, only to end up in kidney failure. The final thing is screening for malignancy. You're immunosuppressed, so you're at higher risk. So we recommend shorter screening intervals for malignancies. The most common are going to be skin cancers. So annual dermatologic exams are a vital, vital part of your health maintenance, and using good sunscreen. Of course, avoiding the sun. I'm a sun worshiper. That's going to be a tough one if I ever need a transplant. But it's really important if you don't want to be covered with skin cancers. And then if we do find a new cancer, then we could often reduce immunosuppressants further to try and slow down the growth and be able to do treatments. Immunizations are very important. Some of them you can't get after transplant. So most transplant programs want to get you fully immunized beforehand, because these infections, which are no big deal, or not necessarily no big deal, but can be easily treated. Somebody who's not immunosuppressed can be deadly post-transplant. After transplant, we'll give boosters. We recommend boosters for flu, COVID, tetanus, pneumonia, hepatitis A and B, because sometimes when you're immunosuppressed, you can't mount those antibodies anymore. You cannot get live attenuated vaccines. Now, there are very few of these. Most of these are if you're going to travel somewhere, like you're going to go and need the smallpox, or you're going to Africa or something like that, yellow fever, you can't get those. So if you are going to travel to some place that requires special vaccines, you do need to talk with your transplant team and maybe the transplant infectious disease doctor to determine if it's something you can get, or is it a place you can go to without it. Obviously, women who've got a transplant, we recommend good contraception. IUDs can be less effective from these medications, and the pill is okay, but it's important to have good contraception. Can you have pregnancies after transplant? Yes, it's risky both to the fetus and to you. And so if somebody is of childbearing age and wants to have a baby, we go through extensive counseling because we do have to remove immunosuppressive medicines, which exposes you to rejecting your heart. And then, as I said, the IUDs are not as effective. And so usually recommend a second method. Okay, you've gotten through college. You've made it. You're now a grown-up. You're going out there to the through world. Usually in those first couple years of those college years, we'll see you less frequently, maybe every 3 months. And then eventually it's usually twice a year. So you're a big kid now, you're out in the real world earning your way. And what can happen then? Well, real life things. Over time, the heart can have problems. It can develop that vasculopathy, or it could get stiff just over many years of the immune system. Cancers can happen, just like they can to that you not being immunosuppressed. They can happen to you, and then going through. So that's why we always want you to stay up to date on the health screening tests for these things, and why we do those annual imagings, CAT scans, ultrasounds, x-rays, looking for signs of these things early. And then, as mentioned, your medical conditions are continuing to go on and can cause their concomitant problems. The good news is that the 50% or mean survival is 13.5 years. Now, when you're looking at a disease that has a 50% 1-year survival going into a heart transplant, that's a really nice years gained. But it's not free. You've got a lot of medicines, you've got a lot of issues that you need to deal with. So my takeaways before we have questions is that this is a rare, precious gift, and you are part of a special club. It's far more complicated than traditional cardiac surgery. So if you've had a prior bypass or valve surgery, markedly different, both in the early post-operative period and lifetime. You know, those you got your surgery, you healed, and you never saw your surgeon again after 6 weeks. You're seeing your transplant team for your entire life. It's a lifelong condition, new meds, new challenges, and you're always going to have a relationship with us. It takes a village to take care of you all. We have great teams, good coordinators and nurse practitioners, your primary care doctor, other specialists that you may need. You need a full team, and they need to all be communicating with each other. And when you do, and you have that, you can have excellent outcomes. So with that, I believe I will stop sharing so we can talk.
Great. Wonderful. Dr. Hall, thank you. Thank you. And by the way, thank you to our sponsor for this webinar, Natera, as well. Incredibly informative. What I'd like to do is offer questions. If you could, put them in the Q&A. Just hit the Q&A and we can field them there. And if you have any comments to make, you're welcome to make those in the chat box as well. First, I have a confession. I didn't realize I flunked kindergarten. But I eventually passed. So
You did. You did.
Yeah, and so with that, it actually had me thinking, and it was based on a question we had as well. So let's talk about post-transplant hospitalization for a moment. You know, you kind of covered the gamut of what can happen and so forth. And so how might you categorize, you know, and how often kind of patients are, say, textbooked, right?
Yeah.
They're in and out. It's a 4 to 6 hour procedure, you know, short recovery, they're back home, versus we'll call maybe mild to moderate to maybe like a complex experience.
Yeah.
I want to kind of share that at a high level.
Yeah. So the common, what I would call the home run, okay? The heart works right out of the gate, no bleeding, gets off the ventilator within 24 hours, in the ICU maybe 2 or 3 days. That's usually a 10-day hospitalization. So that's the home run. That's rare because of all of the things that I mentioned. With our donors are not as healthy, our recipients are sicker, there are more problems at the time and afterwards. So I would say that used to be the norm. I've been doing this now 28 years, and that was most of my transplants back in the day, because we were so selective and very few people could get on a transplant list. Now the world is different. And so that would be the home run. I have had a handful of patients that are out in under a week. Those are like, you know, the grand slams. I mean, that just doesn't happen very often. And one of them was a retransplant, so they already understood everything. They didn't need the teaching. They did great, and they were home on day 5. I would say that the more common good process is more like 14 days. So I would say at least expect 2 weeks without complications. If you have complications, it can be months. And I've had patients living in the ICU for 3 or 4 months, eventually getting to a long-term care facility, and then from there, they're there a couple months, and then inpatient rehab, and finally getting home at like 9 months. That's the worst case scenario, surviving. Obviously, the worst case is not surviving the transplant, which is still about 10% in the first year. It's a 90% 1-year survival, kind of across the country average. Some programs are a little bit better, some are a little bit, but really they're all in that cluster of 90%. And so that would be kind of the range I would give.
Yeah, great. No, that's informative. That helps. So in the meantime, we've had a few really great questions come in.
Well, I think that one was the first question, right? You rephrased it.
Yeah, in fact. One I'd like to jump to. So let's just say a patient develops cancer. And you can probably see it here too. Chemotherapy. How typically is that managed? What's the effect of chemo on a graft?
Yeah, so we essentially treat a heart transplant patient with a malignancy the way we would treat a non-heart transplant. There's nothing out there that says they're at greater risk of chemotherapy-induced cardiac dysfunction. Now, we know that more and more chemotherapy drugs that have been developed, that is one of the risks. Whether they be immune modulators or chemo, we know that many of them now have a risk of cardiac dysfunction. But ultimately, you're looking at which is affecting your survival more, and you got to go after the one that's going to hurt you. In addition, there is a certain type of malignancy that's from the EBV virus, which we actually treat by decreasing your immunosuppression. And so we monitor for that as well. So it's called PTLD, post-transplant lymphoproliferative disorder. So short answer, they do what's recommended for the malignancy regardless of the transplant, and then we deal with if their cardiac dysfunction develops, just like we would if you hadn't had a heart transplant. Yeah,
great. Let's hop over. There was a question, it's in the chat from Robert W. about, we can often lead a fully normal life. He asks, why did you say there are quality of life restrictions? Can you detail, what kind of restrictions you're
so first of all, it's the old adage, Doc, when this is through, can I play the piano? And you say, of course you can. Oh, good. I didn't know how to play the piano before. So we can't fix any problems that aren't related to the heart failure. So that's the first thing, that sometimes people think that all that's going to get better, and it won't. The second is that your nerves no longer talk to your heart. So there are just certain activities that require that. So things that require sudden bursts of cardiac function. So sprinting, climbing, deep sea diving, think more of those extreme things. We don't recommend heart transplant patients go do deep sea scuba diving. Do not climb to the Everest peak. I have one patient who went to the base camp. That was cool. We want your marathon runners, not sprinters and hurdlers. So that's sort of from the performance stuff. Also, you can be prone more to dizziness when you change positions because those nerves aren't telling your heart. And so some of those adjustments, especially as you get older and those nerves are already slower to the blood vessels and there's no nerves to your heart. So you can get lightheaded when you stand up too quickly. So those are specifically related to the heart transplant for quality of life impact.
Yeah, I can attest to to that. But the analogy I've used is, it's like a diesel engine anymore. I can't sprint. It changed my profile of the kind of activities I do, but I just found different activities.
Yeah.
Yeah, yeah. Great. So, future looking out there, what kind of research is being done about the patient not needing immunosuppression medication in the future?
Yeah, we call that tolerance, and tolerance is coming and always will be. It's in the future and always will be. Heart's probably not the organ that's going to be finally cracked. It's probably going to be the liver. So the liver is the most forgiving and can get by with the least amount of immunosuppression. As a matter of fact, when you get a heart liver, your incidence of rejection and vasculopathy go down compared to a heart alone. So I think if they ever crack that, it's obviously done lots of animal models and attempts. It'll be in the liver population first, and then probably the heart second, then the kidneys, and last the lungs. The lungs are incredibly difficult. But there's nothing in the imminent future, like next year's trials or anything like that. It's still in the basic science. It's still the twinkle in the researcher's eye, and we all hope for it one day, but we have not seen anything close to clinical applicability.
While we're on this kind of channel, you want to give a quick update, short update? There's a question here about xenotransplant and 3D printing of hearts.
Yeah, both of those, again, there's been a lot of excitement about xenotransplant. It's certainly not ready for prime time. I know this year we were asked if we wanted to be a center, as a company is looking at trying to breed these pigs. It takes $1 million to make one of these pigs up front, to modulate their immune system and do all the stuff, to then get ready to take the heart and attempt it in a human. And no human has lived very long yet with it. Mm-hmm. So it's definitely not close to prime time. Are we looking at potential more human trials coming probably in the next 2 to 5 years? Yes, I think that we will get to that stage. Those trials will be for patients who are not candidates for human transplant, and they essentially want to give it a shot, hoping they get some time out of it, which is what the current ones who've gone through it have done, but have not survived. That's probably where it will get started. From printing, that's even further away.
Yeah, great. Thank you. I want to kind of generalize a question, which is, do you have patients that just come and say, they might be 3 years out, 5 years out, and just say, I've just never really felt the same.
Yeah.
Yeah. What are some of those causes when we hear that from patients from time to time?
Yeah. No, I hear the same thing, and we have not found physiologic reasons for that, although there are definitely patients who swear they've gotten a new passion for something or new favorite taste or whatever, and then they meet the donor family and they find out that the donor had the same thing. There's these talks about cellular memory. We've never been able to prove any of that physiologically, but there have certainly been anecdotal cases out there where a recipient feels they've gotten some characteristic of the donor. Most of this is the psychological impact of it all. Now, there is the physiologic that we talked about. You can't be the sprinter. You can't be the sudden. The other thing that can affect is cognitive. You're on bypass run. If you had a really rough time and a prolonged recovery, your thinking isn't the same. You're not as crisp. You're not as sharp. We call it pump head. This can happen to patients that are getting bypass surgery, and it's from being on the bypass, and that's not normal perfusion to the brain. And the more complicated the surgery was, the longer you're on that, the more you're at risk for that. And so people will definitely notice they may not be as cognitively as crisp as they used to be. And sometimes, depending upon what you were doing beforehand, it could impact their ability to do that position. I've had CEOs who've stepped down and chosen the moment to retire because they didn't feel they were as crisp as they could be. and then also the emotional, psychological aspects of it all. There's tremendous survivor's guilt associated with it. The fact that somebody died to get provide the organ. Obviously, they didn't die to do this. It was a wonderful gift that came out of the unfortunate thing that happened. But there's lots of guilt that many people go through, anxiety, depression, PTSD. And so having good psychological support, having a good support friends and family around you, as well as professional when needed, is very important if you find yourself in that.
Yeah, that's a wonderful, wonderful way to kind of cover the holistic side of it. You know, I should have mentioned this earlier, and I'm going to mention this real quick for folks. We're actually launching our heart transplant support group. We've had a sponsor come forward to help us out with this. Stay tuned, folks. You'll hear an announcement of that here in the next 60 days. So, little news here at the end. We're at the top of the hour, so I think we're probably going to look to wrap. I think we've got the questions answered from folks that had them out there. You know, thank you again, Dr. Hall, for all of this. And thanks everybody for tuning in. As a quick note, this has been recorded. It'll be posted on the Empower Transplant website, which is mendedhearts.org/empowertransplant. Everyone who's registered will receive a link here in the next day or so with a link to the direct video, which we also hold on our YouTube channel. So the Mended Hearts YouTube channel on the internet. So thank you again, and have a wonderful evening.